coronavirus update. We've been doing this program, speaking to the experts, medical experts and researchers since February, since the beginning of COVID-19 here in Hong Kong. And we're delighted today that we have Professor Peter Horby, Professor of Emerging Infectious Diseases and Global Health and Executive Director of the International Severe Acute Respiratory and Emerging Infection Consortium with us. And we're delighted today, John Power, reporter at South China Morning Post, will help us moderate today's discussion. But before we get to the discussion, just some updates and some numbers. Many of the numbers you're probably well aware of. We have surpassed the 7 million mark globally in terms of the COVID-19, over 400,000 deaths. And Hong Kong, our numbers have increased now to 1106, and still quite low comparatively speaking. And in this neck of the wood, New Zealand is reported COVID-free, and many countries have now reopened or partially reopened its economy since since their various version of the lockdown. And so, and we're really, but unfortunately, collectively, 136,000 cases were reported by WHO, and this is a global number, and it's the most in a single day. So we're now not out of the woods yet, and so that's why today we're really delighted to have Professor Peter Horby to talk about some of the the research and in terms of the trials of drugs that he's working on. And on that note, I'm going to turn it over to John Power, who has been with SCMP reporting on this and various news. So, John, hand it over to you.
Thank you for having me. Professor Horby, you are the chief investigator of the Recovery trial, which is the world's largest trial of potential treatments for COVID-19. Can you give us some sense of the current state of play with your findings and offer us any potential good news that you might have to share at this time?
Yeah, well, thank you very much. And first of all, let me say thank you very much for the invitation from the Asia Society. It's a great pleasure to be here and to answer your questions. Yeah, the Recovery trial is really a UK national effort. It was set up by myself and colleagues in the University of Oxford with the strong backing of government and the NHS. And we have a national health infrastructure, the NIHR, National Institutes for Health Research, and they've all really got behind it, which means that it's been a very large scale effort. So it's now open in more than 170 hospitals in the UK, across all the nations, Scotland, Wales, Northern Ireland, and England, and is recruiting from most of the acute hospitals in the UK. So we've been very successful in recruitment. We've now got over 11,000 patients recruited, which makes it a very large randomized controlled trial, which is what is needed really to get good evidence on whether any of the therapeutics for SARS-CoV-2 work. We've seen a lot of speculation, a lot of small studies, a lot of uncontrolled studies, which are difficult to interpret and really don't give you the strength of data you need to move forward with changing care for patients. So we've gone for a large scale trial. We've been looking now at 6 drugs. So we now have 6 different drugs in the trial. Mm-hmm. And it's a platform trial, which means that we can introduce new drugs when they become available, and then drop drugs when we have a result, either discard them if the evidence is that they're not effective or that they're harmful, or move them into routine care if they're shown to be effective. We're getting to the stage now where we're starting to get answers. People have been saying, you've got 11,000 patients, you must have an answer now. But you have to remember we have 6 drugs and we have a control arm. And if you want to have, say, a 20% reduction in the risk of death, then actually you need quite a lot of patients to see that. So you need about 2,000 patients per arm in the treatment arm and in the control arm to see a 20% reduction in the death rate. And so we just released the results last Friday on the hydroxychloroquine arm, which was stopped for lack of effectiveness. So in that study arm, we had over 1,500 patients in the hydroxychloroquine arm, and more than 3,000 patients in the control arm. So we're doing a 2-to-1 ratio. And really, we saw absolutely no difference in the fatality rate. There was actually a slightly higher fatality rate in the hydroxychloroquine arm, but not significant. So you can only say there's no difference. We saw no difference in any of the other treatment arms. And we saw no difference when you looked by age or gender or by disease severity or by time since disease onset. So really, I think it's fairly conclusive evidence that in hospitalized patients anyway, hydroxychloroquine at the doses we used is not effective. Which I think sometimes there's a disappointment in a negative result, which there should be. You know, we obviously want to find a drug that works, but also hydroxychloroquine is being used on very large scales worldwide, and if it's not effective, we need to know that, stop that, so that we're not diverting resources and focus on better treatments. So we've now stopped enrolment to that arm, and we've also now reached the point where we will soon be declaring a result on the dexamethasone, the steroid control arm, where we've now got 2,000 patients on treatment and 4,000 patients on control. So a result from that will be coming out in the next few weeks.
Okay, well, regarding some of those potential treatments that you're still looking at, is it too early to say data-wise whether there are any effects in terms of gender or age? One of the interesting things about COVID-19 is it seems to affect children less severely and then also affect men more severely. Have you seen that play out to any extent with your findings so far?
So at the moment, the investigators, so myself and the other chief investigator, Martin Landry, we are blinded to the outcome results. So we know how many patients are in the trial, and we know how many patients have been allocated to each of the different treatments, and we know the overall rate of death, but we don't know the rate of death by treatment. So we're kept blind. That we have an independent data monitoring committee who see all of the unblinded data, and they meet every 2 weeks, and they tell us if they see any signals of harm or benefits. And when they do, then they will tell us that, and then they will unblind the data to us. So we don't know the outcomes in the other treatment arms yet. So the only treatment arm that we've seen the results for is the hydroxychloroquine, where we didn't see any difference by age or gender.
Okay. There are some people who believe that this virus may never be fully eradicated. And in that vein, there are some people who say that we might never actually have a vaccine, which of course all of us are hoping for. Do you foresee a scenario where potential treatments fulfill that role of a vaccine and essentially bring us back to normality to a similar degree? And by the same token, will it be a challenge to produce these drugs on the scale that will be necessary to treat people so that we have a situation where we essentially can live life as normally in the future?
I think getting back to normal life really will occur by a combination of three things. One is immunity. You know, natural immunity is one way, and we're seeing that in populations. We're now seeing, you know, in the UK, not high levels of immunity in the community, but in certain risk groups like healthcare workers, we are seeing. There was a recent study I've seen where about 40% of healthcare workers in one hospital had antibodies. And so that gradual accumulation of immunity in the low-risk population, so in children and adults, will help to slow the spread of the virus. And then immunity through vaccination. And I am hopeful about a vaccine. I'm not sure about the time frame. It may take some time, but there's a huge amount of investment in a whole range of vaccines, and I feel fairly confident that we will end up with a vaccine. How well it will perform, I don't know. Whether it will, be one dose and that you'll have lifelong immunity, I doubt that. But you may well end up with a vaccine that, perhaps, at the worst, like the flu vaccine, you might need several doses, and then it will give you some level of immunity. It may not stop you getting infected, but it may stop you getting very sick, which is the most important thing. And then I think the next intervention is then treatments as well. And I think we will move towards more effective treatments. We may not get a a silver bullet, I'm sure, that's going to make sure that everybody survives. But I think with a combination of improved supportive care and a range of therapies, we will be able to improve the survival rate. And so I think it'll be a combination of those three things. Any one on its own, I don't think will be enough.
We are, in a sense, seeing a sort of a global laboratory where different countries are approaching the management of this virus in different ways, and different countries are being hit more severely than others. And a lot of the countries and jurisdictions that are doing quite well, it seems, are in Asia. And one of the common factors, it seems, in this part of the world has been a very high uptake of mask wearing. Very early on in Hong Kong, people spontaneously were wearing masks, largely because of their experience with SARS. Whereas in the Western world, it's been a much slower habit to catch on, including in the UK, I think, which has been very severely hit. Do you think that was a mistake in hindsight? And do you think that and maybe basic hygiene and sanitation and things like that could also be a major factor in controlling the disease?
It's there's so many factors, it's very difficult to pick out one. I think you can pick out masks and look at sort of ecological trends where you look at a country and you look at the mask use and you can say, well, it correlates. But it's never just the mask use. There's all sorts of other things as well. There will be social distancing measures, closing schools, screening at airports, hand sanitization, contact tracing. So there's so many different variables. It's very difficult to say which the contribution of each of the different interventions. I think one of the most important things actually was a very early response with all of those things. So any one of them is unlikely to be the causative factor of all the benefit. Together combined, they will have made the difference. And I think actually it's the timing that is probably the most crucial thing about when you put in place a whole suite of measures. And I think probably what you saw in some European countries is that actually there was an underestimate of the degree of transmission in the countries early on. And so the countries that didn't really realize how bad things were until a late stage, and only at that stage did they introduce the measures. At that time, it was past the sort of the takeoff point, and they were in a situation where they were going to have a very large number of cases. So I think it's the measures, but equally important is the timing.
You've been involved with research and projects with people in this part of the world in China. Can you tell us a little bit about the collaboration with Chinese researchers that you've been working on recently? And also, in that vein, how any of the tensions between China and the US in particular, or other parts of the world, made your job a little bit more difficult in trying to get that collaboration going, sharing information, that kind of thing?
Yes, I've been, I've worked in Asia for a very long time. I lived in Vietnam and Singapore and have long-standing collaborations in the region, and a very long-standing collaboration with colleagues in China, in both Beijing and in Shanghai. And so very early on, around the 2nd of January, I was on the telephone with collaborators in China, talking about planning clinical trials for COVID. So I worked very closely with Professor Chao Bin in Beijing, who was sent to Wuhan and spent many months there leading the clinical trials in Wuhan. And we worked together on 2 clinical trials, one on lopinavir/ritonavir and one on remdesivir, and they were the earliest randomized controlled trials. His group published the first clinical descriptions. His group published the first randomized controlled trial result, and his group published the first placebo-controlled randomized trial from remdesivir. So it really was a magnificent effort. And I think what you've seen is that the life sciences sector in China and parts of Asia is very good. And what we've done is worked at the level of academic collaborators. And really that's the best way to do these things. We can avoid a lot of the political and other tensions by working on an academic to academic level, and just focusing on the science and making sure that we can improve patient care and trying as much as possible to avoid those tensions. not always possible, but that's the best way to do it.
That is sort of a paradox we're seeing at the moment, isn't it? Where, you know, a virus knows no borders, it knows no geopolitical circumstances. And yet, at the time of this pandemic, we are entering a very fraught geopolitical context. Are you in any way concerned about those political tensions interfering with the work of people such as yourself who are trying to, you know, obviously manage diseases like this and other emerging threats?
Yeah, I think, you know, there are certainly risks there. There are risks in terms of funding. You know, we've already seen the US's approach to funding WHO, and we may see similar issues with, you know, funding of research and joint collaborations, which I think is a big mistake. You know, as clinicians and scientists, we're all in this together. And on the academic side, we've worked very closely without any of those sort of geopolitical concerns to try and get the best evidence in a collaborative international way. And that's the only way to do this. And what we've seen, you know, this is an excellent example really, where, you know, we worked together with, you know, colleagues in China in the early stages, and then the epidemic has shifted. So then we have to work together with investigators in Europe, and then as it moves on to Africa and South America, then we need to work together in those areas. So that's what we've been trying to do, and through ISARIC, which is the International Severe Acute and Emerging Infections Consortium, that's a very large consortium of over 100 researchers globally with an interest in clinical research and epidemic infectious diseases, and that's been running for some time, and that is that attempt to really bring together an international federation of researchers from a grassroots level to make sure that we can get the research done. I mean, the other area that politics often raises its head is in data sharing, and this is the other problem. You know, we've got financing, where we don't want a situation where we can't get financing to work with colleagues in China or other countries because of political issues. And we also don't want an issue where it's difficult to share data because of political issues. There's a lot of sensitivity around data around emerging infections and epidemic infections. And it's very sad that that sensitivity at a national, political or geopolitical level interferes with the free sharing of evidence and information and knowledge. And that's a constant battle that we're trying to work against. Really will make a much bigger impact if we share data freely and we combine, you know, intellectual resources to rigorously look at all the data that's available.
And how has your experience been sharing data, particularly in colleagues with China? Have you found there are obstacles there to navigate?
There are obstacles in every country in an epidemic. It's an unfortunate repeated history that you know, when there's data and there's uncertainty and there is, you know, national profile around epidemics, that there is a high degree of sensitivity around access to the data and interpretation of the data, and it's certainly not an exclusive concern for politicians in any one particular country. We've seen it anywhere you see it. We've seen it in all sorts of epidemics. I think you know, I think we need to sort of work with politicians really to educate them that actually, in the long run, transparency works much better. It may give you some short-term gains, but in the long run, you will control the epidemic better and have a better perception of the response if there is complete transparency.
I think especially in the early days of the pandemic, we had a lot of shifting information about how lethal this disease actually was. And I believe your organization last month released a report which found quite a high fatality rate, I think of above 25%, which is much higher than a lot of the news reports we would have seen. Can you speak to that a little bit? Is that an anomaly, or is that reflective of something that isn't very widely understood yet about the disease?
Well, it very much depends on what data you're looking at. So if you're looking at the overall case fatality rate in all infections, which is anybody who's infected, including someone who's got no symptoms at all, which is quite a high proportion of all cases, then the case fatality rate is less than 1%, and that's pretty clear. But then if you look at patients who get to intensive care, who are very sick, largely very old, and largely have other illnesses like diabetes and heart disease, then the case fatality rate is 50%. And then if you look at the broader population of patients who get into hospital, in the UK, through ISERIC, we've looked at a cohort of about 50,000 patients admitted in the UK. And yes, the case fatality rate in those patients is about 25 to 30%, which is very high, and is higher than other countries. But that doesn't necessarily mean that the disease is worse here, or the care is worse here. A lot of it has to do with what's the background age distribution in the population, because the risk of death changes very markedly with age. What's the background rate of other illnesses like diabetes and heart disease? And what's the threshold for admission to hospital? Some places with fewer cases would admit very mild cases almost for quarantine rather than care, and that will really skew your case fatality rate. So it's very difficult to make very crude comparisons between those case fatality rates. You really have to look at the data in some detail and adjust for all these other factors.
One of the questions that's is in many people's minds at the moment is how exactly this pandemic started, how it spread, all the nuts and bolts of how we got to this point today. And that whole issue, of course, has become enmeshed in politics and geopolitical concerns. As a scientist, do you have any thoughts on how important it is to find out where this came from and how we get those answers in a way that's productive and I suppose realistic, working within the constraints that we face?
So I think the urgent issue right now is to get control of the disease internationally. And at the moment, it's a human disease. It's spreading from person to person. There's no animal reservoir. Between people. Can you hear me okay?
Yeah, you just paused first.
Yeah, sorry. We need to, get control of the disease in people through, social distancing measures, hygiene measures, vaccines, treatments, etc. And then the secondary, issue is, well, what was the source of this? And not because we're particularly interested for this outbreak, but to prevent future outbreaks. And all the data I've seen is pretty clear that it's come from an animal source. And we need to look at how we can better identify the risky viruses in animal populations. That's not an easy thing to do, because there's many thousands of different viruses, most of which will have absolutely no implications for human health, and spotting the ones that will is extremely difficult. And then looking at the processes by which that risk of transmission from animals to humans can be mitigated through control measures in terms of interfering with animal ecology, and also the interaction between wild animals and farmed animals and humans, etc. So I think there are lessons there. And we've seen this in the past with avian influenza and SARS-1. Is that there is it's one global ecology, and the pathogens can mix across species, and we have to be very aware of that.
We did have, I think, for years, scientists warn us that we will face a pandemic at some point, and some people would argue that a lot of the political class in all sorts of countries didn't take that seriously enough. Do you think that we've learned our lesson for next time, or are you concerned that maybe we'll make the same mistakes again? And if so, do you have any specific examples where you think the message isn't getting through quite yet?
I'm not overly optimistic. We have seen improvements. I actually was working in Asia during the first SARS outbreak. And we saw a lot of activity after that. But it was fairly short term and fairly low level in terms of the levels of investment. I mean, you're talking tens of millions, but it's a drop in the ocean really when you look at the size of the problem. And then with avian influenza, we saw similar concerns and similar investments. And then after the 2009 pandemic influenza, similar concerns and some investment, but nothing really significant, nothing really structural. And we had a report following the West Africa Ebola outbreak about pandemics, and a group tried to estimate the cost of pandemics, and they said the annualized estimate was $60 billion. So if you took the costs of all pandemics in the last 100 years, averaged them over 100 years, it's $60 billion a year. And I don't think anyone took any notice of that really, because they thought it was a ridiculously large sum. They were right. I mean, that was an underestimate. You look at what this has cost the global economy. It's phenomenal. In the UK alone, the economic costs of the lockdown is huge. I don't know what it is, but across the globe, it is enormous, and you need a level of investment that matches that risk. And okay, that investment may not pay off in 10, 20, 50 years, but you need to make that investment. It needs to be seen like an insurance policy, and it's an insurance policy that may be costly on a day-to-day basis, but may prevent you from a catastrophic loss, as we're seeing now. And that needs to go across many sectors, bioscience research, but also, how societies work and how we interact with animals and how we interfere with ecology, climate science. All of those things need to consider how are our actions impacting on the risk of global pandemics like COVID.
Mm-hmm. And in terms of, obviously, you're a professor at Oxford, how important, and I know the Oxford team are heavily involved in the vaccine question as well, how important do you think institutions like universities are going to be? And do you have any thoughts on the benefits or disadvantages of public versus private research and investment? You have pharmaceutical companies involved in looking for vaccine and treatments, and of course, then you have universities and research institutes. Do you see any benefit to one approach over the other, or should we just try and spread our investment far and wide and have as many options as possible?
I think the best way is partnership. Pharmaceutical partners, industry have a lot to offer. They have a huge experience, a huge R&D departments and R&D budgets, and a lot of experience on getting ideas to be translated into products and then getting them registered and used. Whereas academics have a lot of scientific knowledge and perhaps cutting edge techniques and methodologies, and less of a financial perspective, but more of a blue sky sort of science approach to the problems. And I think the best solution is putting those two things together. I think one thing that needs to be solved, which partly harks back to your last question, is the business model for development of products for epidemic infections, because they're not a reliable market. They often are very unpredictable. They often occur in low-income settings where there's no business to be had, and they're a high-risk proposition for the pharmaceutical industry, which is why you've seen a lot less investment in this area than you have in other areas like chronic diseases, where you have a very clear, stable market and affecting a population that can pay for drugs. And so there's a real issue, I think, around what's the business case. And CEPI, the Coalition for Epidemic Preparedness Innovation, which is the vaccine group, has partly set up to do that, to look at how you can remodel the business case for vaccine development for neglected epidemic diseases. We need the same thing for therapeutics as well. We need a global coalition to look at how we can bring together the public and private sectors to make sure that we have the products available.
What's your outlook for the rest of this year in terms of getting the pandemic under control and returning to something approaching normal life? Are you relatively optimistic that that's something we can look forward to? I mean, obviously it depends on which country you're in as well, but what's your reading of things right now?
I think we have to be very cautious. To be honest, although it feels like it's been a long time since the start of this year, it's the early days really of this. We've seen the first waves, and we've seen some countries been incredibly successful in controlling infection, and I think the news from New Zealand was quite outstanding. But it's too early to call that race won. Once things start relaxing and flights start reopening and international travel restarts and schools restart, etc., there's obviously a very real risk of the second wave of infections. So I don't think we should relax in the slightest. I think we could be in for an equally busy next 6 months, even in countries that have seen large outbreaks. We may not. It may be that actually there was more transmission than we thought, and there's more immunity, and that we have now learnt some of the lessons around social distancing and hand hygiene and masks, etc. That means that we can better live with the virus. But equally, we could be in for a pretty difficult next 6 months. So I remain open-minded, I'm afraid.
In countries like the UK, there's been very fierce debate about the economic cost of the lockdown, which you mentioned earlier, and there have been critics who've said that maybe it's counterproductive. Maybe at a certain point, shutting down the economy causes more harm than the advantages of preventing the disease. Do you give that argument any weight at all, or do you think that the government in your part of the world in particular took the right course of action?
I'm, by training a doctor and a scientist, and so I've always looked at everything through a health lens. But you can look at those issues through a health lens either way. So the lockdown and the economic consequences will also have health consequences. We've seen a drop in rates of cancer screening. We've seen a drop in the rates of people coming to hospital with acute conditions like strokes and heart attacks. I don't think it's because they're not happening. It's probably because they're just not getting to hospital. We've seen in other outbreaks like Ebola in Africa that they lead to a loss of control of other disease measures. There will be associated depression, domestic violence, all sorts of issues that will have arisen because of the lockdown, the economic consequences, etc. And so there are health consequences, and I think we will see in the long run that the health impact of the pandemic has been significant aside from the actual infection itself. So you have to balance those two things. But acutely, we know now that this is a very transmissible virus that in certain subgroups of the population does cause a severe disease with a high risk of death. This is mostly in the elderly. And knowing that, I think we have a responsibility to try and minimize that as much as possible. The politicians have to deal with the other issues about long-term economic consequences and impacts on education and economies, etc. But that's, I think, their issue to deal with, not mine.
Alice, how are we looking for time?
We're 5:55, 20 minutes left.
Okay, so would you like to go to the
Yes.
Q&A? So we have some questions from people watching. Let's just see. So we have a question here. This asks about the UK, but I think you might wish as well to speak a bit more broadly as well. And it's about traveling again. obviously one of the industries that's been really crushed by this has been the aviation industry, and even in countries that have done very well, traveling seems to be more or less off the cards. Do you have any thoughts on when we can look forward to traveling again, and also how we can do that in a safe way that's still, I suppose, feasible economically and practically?
Yeah, it's a difficult question, and one I don't have a ready answer for. One of the difficulties is we still have some uncertainty about the proportion of infections that are asymptomatic and the infectious risk that those asymptomatic people pose. We have a clear idea of the incubation period. It's about 5 days. And so we know that we can screen people and we can quarantine them, and that would reduce the risk. We know that people are infectious before symptom onset. So we know that just screening for symptoms on arrival is not enough. So you would need to do sort of some kind of health surveillance or quarantine after arrival. I think the real issue is those people who don't ever develop symptoms but may be infectious, and how they will contribute to reintroduction of infection to countries, because there really is no easy way of detecting those people and controlling transmission from them. So I think that's one of the uncertainties that makes it rather difficult to answer that question.
There's been a lot of inquiry about when the first patients would have been infected with COVID-19, and it seems that the date for that is potentially getting earlier and earlier. And we've had some recent reports suggesting people may have been infected as far back as August last year. Do you have any thoughts on when this originated, and also how important is it for us to actually know that from a scientific perspective?
Yeah, I don't have a view on that. The data I've seen would is mostly coalescing around fairly recent emergence towards the end of last year. It may be that new data will push that back a bit, but I think it's going to be this is something that's come out fairly recently, and I think it has some importance because it helps us learn the lessons for next time as to how we interpret data. I mean, a lot of the information on the data emergence can be inferred from looking at the rate of genetic evolution of the virus, and looking back from a broader set of viruses to a common ancestor back in time. And so I think this outbreak will be a good test case for those methods and help us refine those methods so we get even better at predicting the earliest emergence of a virus from the genetic data. And that will also help us understand the processes by which it may have crossed over from animal species to humans, which in turn may help us to put in place measures to reduce that risk in the future.
We have a question here as well from someone asking about whether a vaccine or treatment should be mandatory. And I suppose they're alluding to the anti-vaccination sentiment that seems to be rising in many places around the world, including even here in Asia. Is that a concern, that there may be skepticism, and could that potentially impact the public health effort to eradicate or get us pretty close to eradicating the disease?
Well, the first thing is we need a good vaccine, and I think we should put all efforts behind getting a good vaccine. When we have a good vaccine, the extent to which a refusal to use it will impact on control really depends on what the objective of the vaccination is, because your vaccination policy could have different objectives. So for influenza vaccination, for example, the objective is to protect the most vulnerable, in which case you give it to people with illnesses or at a certain age threshold, which means they're at most risk of severe disease. And that may well be the policy that is best for coronavirus too, because what we see is that actually there's a very low risk of severe disease in young, healthy adults and children. And so you may target it at those most at risk, in which case you're not trying to interrupt transmission, you're trying to protect those at risk. And so it doesn't really matter if some people refuse. If, on the other hand, you want to interrupt transmission with the vaccine, you have to vaccinate a very high proportion of the population, and that's the point at which perceptions about the use of the vaccine become very important, because if a significant proportion of the population don't wish to use the vaccine, then it becomes very difficult to interrupt transmission. Issues of making vaccination mandatory are obviously very complex and involve lots of issues around social benefit versus personal liberties, etc.
We've seen just in the last few days and weeks in many countries, there have been protests which have brought huge numbers of people onto the streets to protest police brutality and other issues. And it seems in some cases, effectively, the stay-at-home situation or the lockdowns status quo has kind of disappeared overnight. And we've also seen in some cases, some public experts actually say that they do support these protests for health or other reasons. And that in turn has brought criticism back on some of those experts for politicizing the issue in the eyes of some critics. Do you have any thoughts about the responsibility of public health experts to be seen as above politics? And are you concerned about public experts being drawn into political questions, or do you think that the issue of public health is broad, and, for example, racism, to take that example, is part of that question as well?
Yeah, I don't think it's easy to separate health and public health from politics, because politics influences health in almost every way. The policies you have around social exclusion, the policies you have about tobacco pricing. There's so many ways in which politics and policies affect health, and so you can't really disassociate those two. So, in respect to the specific issue of the protests, in terms of the simple epidemiology of COVID, they won't reduce transmission, that's for sure. If in the UK we've got 1 in 1,000 people currently infected, as an example, then if you put 10,000 people together, then 10 of them will be infected, and they may well transmit that to other people. So it will have some impact. But then, if those events take place with some social distancing and hand hygienes and masks, etc., then maybe it's not a significant effect.
Okay. We have a question here about, there was a recent reports in Hong Kong about kitchen exhaust fans being behind certain clusters. And I know in the past we've had questions about air conditioning, the ventilation systems in airplanes, places like that. Do you have any thoughts on how the nature of the disease spreads in certain environments over others, and how that could inform policy in the future, and maybe even into the longer term, where we think about how to present or prevent infectious diseases in general?
There are a lot of important questions there. It's a respiratory infection predominantly, so it's likely that the route of transmission is primarily through 3 routes. One is large respiratory droplets, which are not airborne. They sort of fall to the ground in a sort of ballistic style. But if you're close to someone, then you can get infected that way. And then those droplets that fall to a surface can then contaminate the surface. And so then you could contaminate your hand and put it in your eyes and nose or mouth and infect yourself that way. And that's the sort of the indirect contact transmission route. And the third way really is aerosol, where there are very small particles that float around in the air. It's not yet clear what's the relative contribution of those 3 things. I would think it's very likely that all 3 are important. And probably in that descending order that I presented them: droplets first, contact and infected surfaces second, and aerosols third. But it may vary by context. So you've seen these outbreaks of many cases associated with choirs, for example. And so it may be that there was aerosol transmission under those particular circumstances. So it does vary by context. and perhaps by individual, that individual people may be more infectious than others. And this brings us to the issue of environmental controls, or any controls. Face masks to try and stop droplet spread, hand hygiene and surface hygiene, or screens to stop droplet spread, and then ultraviolet light and the rate of air transfer, etc., to reduce the risk of transmissions of aerosols. We are still learning about the virus in that sense, and I think it still remains to be seen which of those various control measures are the most effective. And again, as with other things, they're probably most effective in combination.
We spoke about international cooperation and how important that is, and also how that can be hindered by political concerns. When it comes to drugs to treat the disease or a vaccine, do you have any concerns about how those treatments or vaccines will be shared among the world? Because you have teams in the US, you have teams in China, in Britain, all working individually or in some cases collaboratively on this issue. Do you foresee any cases where one country wants to treat its own people first, and therefore you have this bottleneck where some people can't get it? And if so, how do we resolve that ahead of time so we're not left in a situation where some people can't get treated?
Yeah, we should all be working towards the principle of equity of access, so that anything that's shown to be effective, vaccine or a drug, is made available to anyone who needs it, regardless of where they live or their socioeconomic circumstances. That is much easier said than done. There's plenty of history around lack of equitable access to medicines. And I think this is where the large international organizations have to play a role, like the World Health Organization, like the World Bank, etc., where they can both make the moral case and the economic case that there should be no attempts to make large profits. There can be modest recuperation of reasonable costs. There may be tiered pricing based on availability to pay. There may be a situation where the richer countries are subsidizing access to drugs in the poorer countries. But for that to work, it really has to be pushed at the very highest level through those international organizations and large-scale political groups like the G20 and others who can actually lead the way.
You mentioned the WHO, and obviously US President Donald Trump decided that the US would cut its funding to that organization, and the organization in general has received some criticism for some of its advice and some of its decisions. Are you concerned about the damage to the reputation of international organizations like the WHO, which, as you say, will be so important to providing equitable access to any treatments? And do you have any thoughts on how the credibility of organizations like that can be restored going forward?
My view is that WHO is an essential, international organisation that plays an enormously important role, and it needs to be supported more strongly than it currently is. And I think it's a real tragedy that the US is withdrawing funding from the World Health Organization. It should be supporting the World Health Organization to improve in those areas where there is room for improvement. There is always criticism when you hold a position such as WHO, where you are accountable to your member states. There are a great deal of competing interests, and there is no ability to force countries to do things. It has to be partnership and persuasion. They are inevitably open to criticism, but what I've been pleased to see is that the current DG has been very explicit in his openness to review what's gone well and what's gone badly or gone less well, and to make improvements where needed. and we should be supporting WHO to make those improvements.
How are we looking for this?
We should about 5 minutes.
Okay, let me see what else we have been sent in. So we have a question here. Professor John Edmonds said he wish the UK went into lockdown sooner as the delay, quote, cost a lot of lives. Do you think this is a correct analysis and fair criticism? And I suppose as well on that note, I think you alluded to this earlier, but how important do you think just the question of timing actually was as opposed to the particular policies that were taken?
2 or 3 days thinking about it, then you've lost a lot of time.
Do you think that if something like this arises again, that we're going to have to go over these same discussions, or do you think that that lesson has been learned about timing?
I think the difficulty is that
you could argue that the likes of the UK had warning from Asia or Italy or other places and squandered.
I think as I think the saying goes, we're always fighting the last war. There's always a tendency to act based on what the last epidemic said, and avian influenza in Southeast Asia, a lot of the response was preconditioned on the SARS outbreak, and then pandemic flu 2019 was predicated on the prior outbreaks, and then after Ebola, then we saw an Ebola style response to COVID-19. The danger is that the next outbreak, we feel we have to do a COVID-19 style response, when that may not be the right thing to do. It really very much depends on the context, on the characteristics of the virus, in terms of the transmissibility, the route of transmissions, and the disease severity. And so I think you have to really always step back and say, what's this particular epidemic telling me? And not assume that you just get out the playbook from the last epidemic and that's going to work.
And do you think that preconceptions about previous outbreaks were a big issue in the response that we've seen right around the world, I suppose? I'm also curious in that vein, if you think that some of the countries that have done well were in a sense lucky that they just had structures in place and it wasn't something that they necessarily made a conscious decision on. They just happened to fall into the right groove when this arose.
Yeah, I think it's an interesting question again, which should require some thoughtful time on. What we've seen is that some of the countries, particularly in Southeast Asia, have been more affected than some of the countries in Europe, and that may well be because of previous experience with SARS and avian influenza, which was much closer to home in many of those countries. And so there was a much greater sort of situational awareness about the need for acting quickly and the different interventions that could be introduced, and previous experience with introducing those interventions and knowing that you can do it and having confidence that you can, do the things that might appear quite drastic, but that you can do them.
Okay, I think that just about brings us to our time. Thank you so much for taking the time. That was most insightful. And yeah, we really appreciate you coming on.
Great. Thank you, John. Thank you, Alice.
Thank you, Professor Horby. Thank you, John, for this great discussion. We're really delighted that Asia Society Hong Kong can host this update. And stay tuned. Episode 18 is coming up June 30th. So there will be more information about that on our website. And as Professor Horby has said earlier, we are truly in this together. This COVID-19 really knows no boundaries, and I think we are all affected. Unfortunately, I think we sometimes here in Hong Kong, thanks to, I guess, a previous experience with SARS, we might have been a bit more prepared. But I think now looking at other parts of the world, we wish those in Latin America, in Brazil, and other parts of the world much luck as they handle this pandemic in their neck of the woods. And with Asia Society's global network, my colleague had told me in New York, we have 13 centers globally. Last month alone, Asia Society Global Network did about 70 7 programs on COVID-19 related, from policy, politics, to medical research and findings, as well as the anti-discrimination, anti-Asian discrimination that has brought on by COVID-19. So we're really delighted that the Asia Society globally as a family can bring you these programs. So stay tuned on Asia Society's asiasociety.org for more information as we go through this pandemic together. And again, my thanks to Professor Horby and then John for being with us this afternoon. And please stay safe and stay healthy. Even if you're out there protesting, wear your mask. Thank you.